I'm Kieran Anderson. I'm group publisher here at Applied Radiology, and I've got the pleasure of sitting down with Dr. Aaron Sodickson. Dr. Aaron, it's good to see you.
Good to see you.
I'm so glad you could join me. You are the medical director now, the Enterprise Emergency Radiology at Mass General Brigham. Is that correct?
That's right, yeah.
That's a new role?
We've been integrating at Mass General and Brigham and Women's. So
Okay.
yes, trying to bring us all together across our multiple hospitals.
That's great stuff. And today we're going to talk a little bit about some of the new and exciting advances in CT imaging,
Yes.
primarily photon-counting CT. That's really beginning to kind of reshape the clinical practice and the landscape. It's been doing so, I think, for the last couple years, maybe in the larger academic centers like yourselves, but we're now, or at least I'm hearing, it's breaking out into the community. And I'm interested to learn more about, this as imaging volumes rise and, there become all these diagnostic questions. They become more nuanced, really, like radiologists are seeking better technologies. They want to be able to see more, better details in the images and things of that nature. They want more confidence. I'm assuming all of that sounds and resonates with you, right?
For sure, yeah.
So photon counting, it promises to do this. Do you envision this? Do you see this to be a reality today?
Yeah, so we put a photon counting scanner in our ER about 2 years ago now, and we've been using it routinely on all of our ER patients. And so we have been finding a lot of potential benefits: reduced radiation dose, high resolution for some applications, particularly musculoskeletal imaging is gorgeous, and a lot more spectral imaging as well.
Right. Are there any other areas within sort of, the enterprise there that you're finding it useful outside of those too?
Well, so there are certainly a lot of applications of those enabling, features of the technology. And, we can talk about better characterization of pathology when we find it. One of the interesting things that we've been doing is a lot more standardization of image appearance using KEV images rather than KVP images, so that we can have more consistency in how our images appear.
Is that tied to like the spectral aspects?
It is, yeah. So basically what we're doing is inherently using spectral processing for everything that we do. And one of the interesting features is we can kind of decouple how we acquire the images from how we look at the images. And in the case of pulmonary embolus CT, for example,
right,
we always use very low KEV for better vascular visualization, while we use mid-range KEV for soft tissue assessment. So we can sort of pair the image appearance with the pathology we're trying to detect.
That's fantastic. When you think about it from a workflow perspective, how has that, kind of changed, when you think about, having to do repeat scans,
Yep.
From time to time. Obviously the goal is to get it right the first time.
Yeah.
Let's talk a little bit about what that, looks like in a busy environment, like an emergency department where you are.
Yeah, well, the pulmonary embolus CT example is a great one. Most of us have gotten used to a fairly high repeat rate, a failure rate, essentially, which we've basically eliminated with the tricks that I mentioned to you. A bit of an optimized IV contrast infusion, low KEV imaging. We essentially no longer need to repeat any of these scans because we can always eke out enough from the contrast that we managed to get in. So that's one example of avoiding repeats based on poor image quality.
Right.
There are others, many others, where we can use spectral information to avoid repeat scans. So if you take head CT and you have a bright spot that we can't normally differentiate between a focus of calcification and hemorrhage, with a research application we've developed, we can now do that with the first scan. We don't need to hold the patient in the ED, do a repeat scan to see if there's change. And then the final area, which is sort of bigger picture, is incidental lesions. We see a lot of these in the ED, and one of the exciting areas of dual energy or spectral imaging in general is if we can more completely characterize them when we first find them, we can avoid a lot of downstream testing, a lot of patient anxiety, resource utilization, et cetera.
That makes an awful lot of sense.
Yeah.
What about patient population? Are there certain groups that may benefit more from the use of photon counting versus, other CT technologies as you think about it? I mean, particularly, I know in the ED you get everybody coming in, but, I don't know, are there anybody who you think could benefit more from it?
Yeah, so since we don't know what we're going to find ahead of time, to me, one of the most exciting areas is this management of incidental lesions. And so patients that come in with unexpected findings, we can really help clarify up front, is this a benign nothing, no further concern needed, or do we need to route them into a follow-up pathway? Certainly with some of the radiation dose reduction capabilities, people are interested in pediatric imaging populations or patients getting a lot of recurrent imaging over time that would benefit from further radiation dose reductions. But I really like to think of it from the population perspective. How can we reduce downstream testing with more definitive diagnosis up front?
Right, right. And as you take a look forward,
Yeah.
crystal ball, right?
Yeah.
I mean, we've evolved an awful lot in
Yeah.
CT since you and I first met. I mean, I don't want to age us, Aaron, but it's
Couple
20 plus
decades,
years.
a decade maybe. Yeah.
I mean, we've seen 16 slice to 32, 64. It's evolved, and obviously photon counting is what everybody's talking about today. What goes beyond that? What's next? Or how does photon counting continue to evolve?
Yeah, well, so I think there are a lot of new capabilities. Some of the high resolution capabilities are really unprecedented. My hope is that this helps us get to more routine adoption of spectral or dual energy information. We've had a bit of an adoption gap over the years. And I think my hope is that by making this sort of regularly integrated as part of the scan, we can break through and take advantage of all this extra information that's available that right now we're usually leaving on the table unused.
That's so interesting that you say that, because I think that's really a key component. And when you think about managing the patients the best way we can, because there's, like you said, there's all of this information that we're not really using, but it's there, right? And you can go back and look at it
Yes,
as well.
that's right.
And that also probably helps with less repeat scans too.
For sure.
For sure.
Yeah.
Well, Dr. Sodickson, I mean, so much is happening in this area of CT. You're on the cutting edge of it. I want to thank you again for stopping by the Applied Radiology booth here to talk a little bit about it.
My pleasure. Always great to see you.